Hello.
Hello, am I audible?
Uh, yes,
Can you
sir.
hear
You
me?
can start with it. Yes,
Yeah,
sir.
yeah. Okay, we'll start in 2 minutes time. Just 2 minutes.
Okay.
Okay. Asmita, shall I start?
Yes, sir. You
Yeah. Okay. Thank you. So good evening to all of you. First, I'm going to show you 3 short cases followed by 2 long cases. So let me share my slide. Is my screen seen?
noted,
Hello?
sir.
Am I audible?
Yes, sir.
Yes,
Am Am I audible?
Yes,
Hello?
sir. Yes, sir, you're audible, sir.
Am I audible to you?
Yes, sir. Sir, you can start your screen is showing.
There is some problem. I'll just check once again and then come back to you. No, okay. Am I audible now?
Yes, sir.
Okay. Can see me, see the slides also, no?
Yes.
Okay. Yeah. So as usual, we start with the three short cases first. This is a story of a 14-year-old boy. He came with the history of difficulty in writing,
not invisible.
abnormal posturing, and tremulousness with the right hand for the last 4 years, which has increased for the last 2 months. No other complaint. No positive family history. This is the video of the boy. His speech is normal. No, there is no dysarthria. Movements. He cannot sustain his upper limb. He has some dystonic posting of the right shoulder. Rest of the CNX examiner is normal. There is no motor weakness. Reflexes for normal. Sense system. The reflexes are all normally elicited. I'll need to. That's a patient. This is the second part of the video. He has to keep his hands outstretched. There is no real incoordination, only jerky movements due to the myoclonus. And this is how he's writing. You can read the way he writes. You can see the dystonic posturing of the hand muscles, shoulder, and elbow. Also got jerky movements of the right hand. Again, starts rating hand goes into dystonia position. So an examination is dystonic posture in the right hand, associated with myoclonus and irregular tremor of the right upper limb, especially while keeping his hand outstretched, more so while writing. And myoclonic jerking of the neck and arm occasionally. The rest of the scene is normal. This MRI was normal, serum ceruloplasmin normal, no KFP. So what do you think is the mostly likely diagnosis in this patient?
Myoclonic dystonia.
Okay, yeah.
11.
Pardon?
DYT 11.
DYT 11, okay, myoclonic dystonia, same as myoclonic dystonia. Okay. It's a good thought. I also thought so. See, I'll see another case now. Two similar cases. This is a story of a 21-year-old woman. She gave the history of tremor of the head associated with jerky movements of the right hand for the last 3 years. Sorry. History of occasional dropping of the objects from the hand. Episodic forward movement of the trunk and neck for 1 year duration. This is the video of the girl, lady. And see the jerky movement of the head. You can see the myoclonic jerks coming in between. That's a myoclonic jerk. It's a myoclonic. Pardon? I'll come. This also you can see the jerks. Okay, and so the second part of the video, she says to us to write. You can look at the neck and head, it goes into myoclonic jerks in between. Okay. So let's see similar case now. This is another girl. She has got significant dystonia of the hand while writing. She also got a jerking movements of the hand as well as the neck. You see the myoclonic jerk.
Sir, dystonic myoclonus, sir.
Okay, myoclonic dystonia, the same as. So all the 3 patients have got the same diagnosis or any difference of opinion? I can say rest of the video. This is the second part of the third girl which I've shown now. Third patient. Look
Second
at
case, PME syndrome.
Pardon? PME. But he has no other neurological deficit apart from myoclonus and no mental retardation, no ataxia, nothing.
Unwards Lundberg's.
This myoclonus is not like myoclonic dystonia.
No, this is no, it's not a progressive myoclonic epilepsy. To call your unworked, it will be progressive. This is not progressive. And usually they have associated features like cerebellar ataxia and things like this. Nothing like this. It's only myoclonus and dystonia.
Sir,
Do you
second
think
case
all the
only,
3 cases belong to the same category or any difference in their
No.
presentation?
second case only PME syndrome.
I think, sir, this is not actually PME because it is not progressive.
It's
So
not progressive.
so this is not PME. So what do you think about the dystonia myoclonus syndrome?
Yeah,
Out of this
it's not
dystonia
PME at all.
myoclonus, predominantly this is involving the upper part of the body. If you look this thing, this
Correct,
mainly
correct.
the lower part is not involved, only the upper part. Mainly the trunk as well as in the
So, no,
upper
the thing
limb.
is all are affecting the upper limb. All of them got dystonia. All of them got myoclonus.
Myoclonus.
So
So
there is
first
some
time,
difference in the myoclonus occurring in the first case and the second and third
yes,
case.
sir, yes, sir, yes, sir.
The second, third case, the myoclonus is quick, lightning like myoclonus come in between. The first case, myoclonus occur mainly during posturing of the hand. When the patient attempts to do something, the myoclonus appears. But the lady comes in between, just like the baby, just stand, look at this particular lady. She just standing, jerk comes in between. That's the myoclonus. See? The other one, when the patient attempts to move, the limb goes into myoclonus. Let us see the diagnosis now. The second and third case have the same diagnosis.
SGC is one. Myoclonic dystonia SGC is one. So one is your DYT11 and rest will be the SGC.
I'll come to that. So the second and third case are the same, myoclonic dystonia. That is, this is a genetic report of the second case. That it shows the classical, the sarcoglycan gene abnormality. This is a third case, again, the same myoclonic dystonia, sarcoglycan gene abnormality. Now let us go to the first case now, this particular boy. Now look at the dystonic, the myoclonus of this particular boy. It occurs mainly when trying to attempt to move, it comes. The other occurs on, of course, it's present at other times also, but predominantly occurs at other times, and it's a lightning type of jerk in the other two ladies. Here it is not like that. This is DYT1. That is the torsion dystonia. TORA1A gene abnormality. That is a dystonia type 1. So sometimes classical teaching is that the dystonia, torsion dystonia, dystonia muscular deformans usually starts in the lower limb and then progress to the upper limb. But that need not be the case. Sometimes it can start in the upper limb. Initially, we used to say that if it's upper limb involvement and the same thing of TAP1 and GNE, something like that. But usually, classical TORA1A starts in the lower limb. But sometimes it can start in the upper limb, mimicking a myoclonic dystonia. That is why these three cases have been brought. Just like as you said, I also thought the first case was myoclonic dystonia. But there the dystonia were prominent and the myoclonus was not that prominent. Sometimes you can get confused between the two. Okay, any questions before I go to the proper case? Shall I go to the next case?
The first case, dystonia appears to be very subtle. Sorry, myoclonus appears to be very subtle, sir.
Correct. It is there, not very prominent. The second one, the characteristic feature of myoclonic dystonia is the so-called lightning jerk. Suddenly it comes like that. That is a characteristic of myoclonic dystonia of the DYT11. On the other hand, myoclonus seen in the dystonia per se are not that lightning jerk. You can see the third color, which was sudden jerk like that. Okay, shall I go to the next case?
Yes, sir.
Okay, so this is again another short case. 74-year-old man, it is an old case of benign essential tremor on my treatment, who had been receiving mycolone. This elderly gentleman has also got postural hypertension, for which I had put him on Pluricort. But he has now come with history of radiating pain on the right face for the last 1 month. I noticed numbness of the right little finger and middle part of the palm for the last 4 months. I noticed pain and numbness of the dorsum of the right foot and in the anterior part of the thigh for the last 1 month. So I think again, this is the old case of benign essential tremor and postural hypertension. Now come with radiating pain on the face, numbness of the right little finger and middle part of the palm, and numbness of the dorsum of the foot, and pain in the anterior part of the thigh. You can hear the story of the patient. He will tell you. That is area is telling the numbness is. He will tell you where up to where this numbness is. That is the area is telling. There's no weakness, no other complaints. You can hold everything, take hold everything. No complaints pertaining to the left hand. Then he is telling you where exactly he felt that numbness. Sometimes pain over the anterior thigh also. ഇവിടെയും അവിടെയും പെരുക്കുന്നുണ്ട്. ഈ കാൽപാദത്തിന് പെരുപ്പ് വേണ്ടിയിട്ട് എത്ര ദിവസമായി? That's for 1 month. That's what he said. There is no other complaint. Okay, let us see the examination. There's no Horner syndrome, upper limb power, biceps deltoid, biceps normal. This extension was normal. The introduction was slightly weak on the right side. That is slightly weak on the right side. Left side it is normal. That is quite normal. If D was also normal on the left side, it is weak. Adductor pulse is also weak on the right side. Common sinus possibility. That is also weak. Come to the lower limb, plexus of the hip, knee extension is all normal. Knee muscle weakness, flexion is normal. But the EHL was weak. That is weak on the right side. That is weak. All of the muscles were normal. Inversion was also normal. It's also normal. Initially, he could pull tight. It's also normal. Abduction was normal. Reflexes in the upper lips normally elicited. Just 1 plus. Finger pressure was absent. DJ says a flicker of contraction there. They can see that. Plantar reflex there. Since system examination, upper lips were normal. But decreased on the dose of the foot. Can you see my video now?
Yes, sir. Yes.
Okay. There's some problem in between. Vibration. Vibrations is normal bilateral. That is decrease over the dose of the foot. You could walk on it. So, on examination, he has got bilateral coarse postal tremor, failures normal, motor system, the right upper limb, weakness of hypothenar muscles, introche, adductor pollice on the right side, rest of the muscles normal, left upper limb all normal. The right lower limb weakness is confined to the right EHL. Rest of the muscles were normal. Left lower limb normal. DTR upper limb all normal. In the lower limb, knee jerks just flicker of movement. Ankle jerks normally elicited. Sensory system upper limbs normal. In the lower limb, pain was impaired of the dorsum of the foot. Can walk on heel and toes. So where is the localization and probable what could be the etiology in this lesion before we go to the investigations?
The mononeuritis multiplex.
Right, very good. Mononeuritis multiplex affecting maybe ulnar peroneal. Correct, perfectly right.
But he has got a facial something, huh? Facial pain.
He complained of facial pain, but that was episodic. But on examination, there was nothing abnormal in the cranial examination. So, what test do you need now? NCS,
Nerve conduction first.
Okay, this is nerve conduction. So, the ulnar now shows decreased amplitude below elbow, but the wrist amplitude was 8.8 normal. There seems to be a conduction block at the level of the forearm. Then the right peroneal, the amplitude is low. Rest of the nerves are quite normal. Left tibial normal. And you see that all the FAs is prolonged, both median and both ulnar. The lower limb, they appear the borderline, but normal. And the sensory has got absent sensory in the both sural. And what is more significant is the absent sensory in the right superficial peroneal, or decreased amplitude, snap amplitude compared to the opposite side. Normal side, that is 11.1, on the affected side, it was 5.2.
Ulnar is normal, huh?
Ulnar sensory is normal. Ulnar sensory, this is right median, right ulnar, is normal, 28 and 25.
What about blink reflex was done, sir?
Blink was not done. Because why I did not know, because facial nerve was not affected, sensory was not there in the clinically sensory was not affected in the face. So what do you think?
Peak latencies of median and ulnar are prolonged, sir. Peak latency sensory.
Sensory you can see here, no? There is prolonged, slightly prolonged. But so the median of always will take you which a pinch of salt can be unrelated carpal syndrome. So many times these peak latency not give much significance. Moreover, this affected nerve was the right ulnar, but that latency was normal.
Can do an MRI of brain because he has got facial symptoms.
Yeah, that we can do. Okay. So he has got mononeuritis multiplex, something, some features as you a demyelinating lesion, but not very convincing about it. Because why demyelination? Because FA is a prolonged, even though the distal latency was normal in the other nerves, median ulnar nerves. See, this is the ulnar nerve amplitude, but the proximal, there is a proximal block and FA is prolonged. The median, these are all normal, still the FA is prolonged. This is a completely confusing picture. So what do you like to do now? Obviously, it's a mononeuritis multiplex, but not the classical axonal type of what you see in vasculitis, some odd type of mononeuritis multiplex.
Yes, sir.
Okay. So the other investigation done were blood parameters were done, and ANA showed Rho 52 is positive, 15. Other things were negative. So what else you like to do?
CSF analysis.
CSF. Right, CSF suspecting a demyelinating neuropathy, like thing.
Yes, sir.
Yeah, correct. No, but See the age of the patient. He's quite old, coming in, had mononeuritis multiplex developing first time in this age group. What would you consider first?
Paraneoplastic.
Paraneoplastic. So CT abdomen was done. That is normal. So FDG PET was taken. That shows metabolically active irregular soft tissue mass lesion with the speculated margins toward the subdural aspect of the left lung under the left upper lobe with the perilesional ground glass reticulations. Then we did a CT chest. This is CT chest. See, that's a mass there with speculated margins outside. It's typical of a malignant lesion there. Again, you can see the mass adjoining the pleural. So a patient underwent a biopsy, their biopsy report has to come now. It's most likely a malignancy. So most likely the patient what had was a paraneoplastic syndrome producing mononeuritis multiplex. So this is described because sometimes vasculopathy, vasculitic mononeuritis multiplex due to vasculitis can occur with as a paraneoplastic syndrome or a paraneoplastic vasculitis. So that's why I thought it's not very common, but that's why this case has been brought. See, the older age group, when you get mononeuritis for the first time, always consider this possibility in the back of the mind.
A vasculitis related will be axonal, no, sir?
Yeah, it's axonal, correct. Perfectly right, it's axonal. So this is, yeah. No, we cannot call this vasculitis. Perfectly what you said is correct. This is a mononeuritis multiplex of some atypical, it's not axonal type, but there is evidence of axonal also because, so not axonal, demyelination is there, but that's what I said. It's not a quite common garden variety of a mononeuritis multiplex, some atypicality. So some immune-mediated attack on the nerves has been kept. In the older age group, when it comes, the immune-mediated attack may be an autoimmune phenomenon, second as a part of a paraneoplastic syndrome. Apart from that, paraneoplastic vasculitis also been described.
Did the PET scan show anything in the brain?
PET scan, brain was normal. This whole body PET was done, that was normal. The thing is that the suspicion should come from that NCS, which shows when the multiple nerves are affected, some demyelinating type of pattern. So in this age group, that means some immune-mediated attack is there. So in this age group, we have to consider paraneoplastic syndrome producing an immune-mediated attack on the nerves. That is why it was planned for other investigations.
Blink reflex was done, sir, for the face.
Blink was not done. Okay, shall I go for the next case? Any questions in this case? Okay, shall I go to the next case? Yeah, please, yeah, Joy.
No questions.
Okay, right. Now, this is a story of a 70-year-old man. This you have to concentrate on this case a little bit. He was apparently all right till one day prior to admission, when he noticed blurring of vision and vertical diplopia associated with imbalance while walking, a tendency to fall to the left side. So blurring of vision and vertical diplopia according to me is more on looking to the right and down, predominantly to the right. And imbalance while walking and tendency to fall to the left side. He was telling that the diplopia is more on looking to the right. He is hypertensive and diabetic on treatment. So this is the position of his head. His head is tilted to the left side. That is the primary position. Looking to the right.
വെല്ല് നോക്കണേ.
Looking up and out to the right, down and left to the left, up and out to the left,
താഴെ നോക്ക്.
towards left and down, straight down,
താഴെ നോക്കി. ഇനി ഇവിടെ നോക്ക്.
right and down, right up, straight up,
ഇവിടെ
up and left,
മുകളിലോട്ട്. ഇവിടെ
down and left.
ശരി. ഇനി എന്റെ വിരലിമ്പത്ത് നോക്ക്. മൂക്കിന്റെ അറ്റത്ത് നോക്ക്. നോക്ക് നോക്ക് നോക്ക്.
Convergence is
നോക്കിയില്ല
present.
നോക്കിയില്ല നോക്കിയില്ല. മതി മതി. ഒന്നുകൂടെ നോക്കിക്കാ. ഇനി എന്റെ വിരൽ നോക്ക്. ഒന്നുകൂടെ മൂക്കിന്റെ തുമ്പത്ത് നോക്കിക്കേ. നോക്ക് 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 നോക്ക്.
Okay, I'll show the video once again. The ocular movements part.
കാണത്തെ കാണേ. എന്റെ വിരല് കാണാമോ? വിരലോട്ട് വിരലോട്ട് നോക്ക്. വിറങ്ങും നോക്കണ്ട. എന്റെ വിരലിൽ
Look to the
തന്നെ
left,
നോക്കണേ.
right and down,
വിരല് നോക്കണേ. ഇങ്ങോട്ട് നോക്കാം.
up and out,
രണ്ട് കണ്ടു മതി. ഇങ്ങോട്ട് താഴെ നോക്ക്. ഇവിടെ നോക്കിച്ചാ താഴെ നോക്കി. ഇനി ഇവിടെ നോക്ക്.
up and out, straight up,
ഇവിടെ മുകളിലോട്ട്. ഇവിടെ ശരി. ഇനി എന്റെ വിരലിമ്പത്ത് നോക്ക്. മൂക്കിന്റെ അറ്റത്ത് നോക്ക്. നോക്ക് നോക്ക് നോക്ക്. നോക്കിയില്ല നോക്കിയില്ല നോക്കിയില്ല. മതി മതി. ഒന്നുകൂടെ നോക്കിക്കാ. ഇനി എന്റെ
so on examination, you had head tilt to the left. And what do you find on examination, the ocular movements? And what is your localization regarding the ocular movements?
Right downward movement is less, and the left upward movement on adduction and abduction is everything is impaired.
Correct. So, which muscle do you think would have been weak in this patient? Or
So left superior rectus, left inferior oblique, and not sure that the right inferior rectus also is impaired because it's not going down fully on right
it
down
is.
position.
No, it's not superior rectus. It's not superior rectus. It's right inferior rectus or left inferior oblique. I'll tell you this. I'll show you. See the position of the eye. Okay, right eye is up, left eye is down. That means the depression on the abduction position should have been on the right side, or elevation or the left inferior oblique. Correct? One of these must should have been weak.
Sir, can you repeat again?
Okay.
Now the
Am I
video is not
audible?
seen. Sir.
There is
Sir,
some
can you
problem.
repeat the statement? Can you repeat, sir? Can you repeat the statement?
Yeah, your video is not seen. You are heard, but your video is not seen now.
Am I audible?
Yes, sir.
Yeah, we can hear, but the video is not seen. Yeah, now it's there.
Okay, there's some problem with the internet connection. I don't know. It's going. It's showing fluctuation. That's the thing. Now you can see the video. Not the video. Now it's only the static film I'm shown. Okay, you see the right eye is up, left eye is down. Okay, that is very clear. And looking out means on the right side means it should be weakness of the right inferior,
Right inferior rectus or left?
left inferior oblique. Correct. So right eye is up, left eye is down on looking into the right side. So is it right inferior rectus palsy or a left inferior oblique palsy? Correct. These are the two possibilities, or something else. This is the diagnostic problem. Let us see. Let us say, is it right inferior rectus or left inferior palsy? Could it be right? Let's first think about, is it right inferior rectus palsy or not? Is there any point against?
Right.
He's tilting his head to the right side. Says 4 right inferior rectus.
I didn't hear. Can you tell it once again?
He is tilting the head to the right side, no? So it's 4.
Correct.
That can go with rectus palsy.
No, his actually head is tilted to the. See, the tilt is to the left side. See, this is the tilt.
Left side.
This is the tilt to the left side.
So that's against inferior rectus.
So in fact, if it had been an inferior rectus on the right side, in which direction should have been the head tilted?
Upward, it would have been gone to the upside, sir.
Oh, that's correct. That's one part. But more importantly, in terms of rotation.
Rotation would not, it would be the reverse way.
Yeah, in fact, rotation is classically seen in only oblique paralysis. Infractive weakness.
In superior
Yeah,
oblique paralysis, we classically see when patient goes downstairs in superior oblique.
Yeah, that tilt I'm talking, your answer is correct. Superior oblique, the tilt is down and to the opposite side.
Opposite
Correct.
side.
Right. But here we are talking about the inferior oblique, not superior oblique. Inferior oblique on the left side, right inferior rectus. Let us first consider inferior rectus on the right side. If it is inferior rectus on the right side, in which direction will the head will turn, if at all it turns?
To the same side.
It should turn to the
same side.
Same side.
Because why it is so the head turns in the direction of the action of the muscle. The inferior rectus is an external rotator. So the head should go to the right. Here it is gone to the left. So we can explain the upward right hypothesis of the inferior rectus palsy. What is the point? Again, is that head tilt is to the left, to the left side. If at all right inferior rectus is to produce a head tilt, it should be to the right side. So always remember the dictum. The head turns in the direction of action of the paralyzed muscle. So for example, if I got the right lateral rectus weakness, my head will turn to the right side. If my left medial rectus weakness, again, head will turn to the right side. Right medial rectus is weak, my head turn to the left side. So wherever the direction of action, that is in which head turns. Suppose you have got a right superior oblique weakness. Superior oblique is a depressor, inductor, and an abductor. So since it is a depressor, head will come down. Since it's an inductor, the right eye is affected. I induct the head, turn to this side, and an abduct means, the abduction means I turn the head lightly abducted. So that's the position they adopt. Easy to remember. Just remember the action. That's the direction in which the head turns. So in the case of inferior rectus paralysis, inferior rectus is an extorter. So if inferior rectus is paralyzed on the right side, my head will extort. It will be in the extort position. That means it will turn the head to the same side. That must eye is extorting. That will turn to the right side. Here the head is turned to the opposite side. So that means it is not inferior rectus. Let's remember the dictum. Extraocular muscle paralysis head tilt is always the direction of action of the muscle. Since inferior rectus is an extorter, if right inferior rectus is affected, the head tilt should have been to the right. Now let us say, is it inferior rectus, inferior oblique palsy here? Is there anything against a left inferior oblique?
Yes, sir. There is a left inferior oblique palsy.
Yeah, correct.
Other video, we have seen that the eye is not going down.
Yeah. So inferior oblique is an elevator. So when there is a paralyzed, eye will go to the down. That's correct. Here left eye is down. Secondly, inferior oblique is an extorter. So that tallies with our head position as well as the position of the eye. It says left inferior oblique palsy. Correct? Okay. Okay.
Yes, sir.
Now, again, so we want to confirm it by any other. Is there any other way to confirm it is oblique palsy in this patient?
Sir, is there any accommodation failure?
So is that
oblique?
right inferior?
Is there any
accommodation failure in
Hello?
this case? In the last part of the video, is there any accommodation failure?
Hello?
When the patient is asked to look towards the nose, the left eye is not coming.
Hello?
Yes, sir.
Yeah, right. Okay.
Is there any accommodation failure, sir?
No accommodation failure. Nothing.
But when the patient is asked to look towards the nose, the right eye is not coming.
Yeah,
Left
yeah,
eye.
And there's mild restriction, but that's not significant in our case because that's not going to differentiate between the two.
Yes,
Our
sir.
aim,
Okay. Okay.
yeah,
Okay.
that's
Okay.
the
We can do a head tilt test, sir.
correct.
shows here.
Say wheel
So
shows
is
this.
that
In oblique, isolated oblique palsy, you can confirm it by doing the. Yeah, your voice is breaking. Yeah, that's
inferior rectus weakness inhibition palsy?
I couldn't hear it. Joy, can you repeat the
Inhibitional
sentence?
palsy?
No, not inhibitional palsy. But you have to confirm.
Yeah,
no?
is that the right eye is not going down on abduction? No? Is that in?
Some problem in the voice anyway.
The sir is asking that right eye is not going down during the convergence. Is it inhibition palsy?
No. That, in fact,
Not during convergence.
no, it's not convergence. He's got not cooperating very well, but whatever it is, some restriction is there, but that is not matter in our case. Our case is got diplopia or looking to the looking down and out.
No, not during convergence.
Yeah.
When he's looking down and to the right side, the
Yeah.
inferior rectus apparently looks weak. Is that inhibitional palsy?
No, not inhibitional palsy. It can be either inferior rectus palsy or a left inferior oblique palsy. Either of the possibility. Okay, so the head tilt all favors.
If there is inferior oblique weakness, why can't the inferior rectus act?
No, no. The only thing is it depends upon where the
If
patient
there is
is
a
cooperating.
inferior oblique weakness, why?
He's focusing on the line on with the inferior oblique weakness. What will happen? Mean the eye will go down. Suppose you look into the right side, the left eye will go down. The right eye will be looking at the object. Left eye will be more looking down. The disparity will be there.
But why can't the inferior?
It could be inferior oblique. Right to be. So this posture and this vertical disconjugation which you see in here can be seen with right inferior rectus or left inferior oblique. Both are correct. But what I'm trying to say is that which among the two is correct, you have to do the other. One is head tilt. Head tilt is favoring left inferior oblique. The downward position also favoring inferior oblique. So of the thing, that's a muscle which is clinically affected. But we have to confirm it by some other method. That is why Wheel's is a rotation test. For oblique palsy, this test is useful, whether it is there or not. Because in one direction it get compensated and corrected, the other direction it will become worse. Okay. So here what I did was this is the he's telling you look at the right side is
രണ്ടായിട്ട് കാണുമ്പോ ഇപ്പൊ രണ്ടായിട്ടാണ് കാണുന്നത് അല്ലേ ഇപ്പോഴോ
looking up is one,
ഇപ്പോഴേ
that is two,
ഇപ്പൊ ഒന്ന് ഇപ്പൊ
is one,
രണ്ടാണ്
again one.
ഇപ്പൊ ഒന്നോ രണ്ടോ ഇപ്പോഴും ഒന്ന് ശരി ഇനി ഇങ്ങനെ ഇരിക്കുമ്പോഴേ ഇപ്പൊ
Turning to the left side.
ഇപ്പോഴെങ്ങനെയാ
two,
ഒന്നോ രണ്ടോ രണ്ട് ഇങ്ങോട്ട് നോക്കി ഇപ്പോഴോ
so what you observed was that
കൂടുതൽ രണ്ടായിട്ട്
even if you turn the head to the left side or the right side, it continues to see as double. In fact, if inferior oblique is paralyzed, if you turn the head to the right side, it will become more prominent, or the same thing should have been disappearing, but it is not disappearing. So what does it mean? It is not an oblique palsy. The superior oblique palsy is the other way around. They turn the head to the same side, the diplopia should, because make it indoor, should become more. The other way around here, to the opposite side, diplopia should have been more inferior oblique palsy. So whatever it is, it should have been corrected on one direction, made worse in the other direction. But in this case, it is the same. It does not get corrected by rotation to either direction. That means it is unlikely to be inferior oblique. So even though
could be multiple ones, no?
If there is a multiple muscles affected, you will not get Wilczewski is not going to help us. One of the pitfall in Wilczewski is that when more than one muscle is affected, it is not valid. This test cannot be used.
So that may be the case here, no? Because it's not used.
Right, that may be the case, correct. So does not produce any change in the diplopia, is present only obtained the head to either direct. Let us see. This will tell you that vertical separation not due to one particular metatarsal muscle paralysis. So what else you do? Now let us see the frames once again very carefully. The one which I have shown earlier. It's got a head tilt to the left side. Then this is the primary position. If the right eye is up, left eye is down. Okay. Now looking to the right and down. Again, right eye is up, left eye is down. That's the one which I have shown earlier. Looking up to the right again, the right eye is up, left eye is low. That vertical separation is maintained in all directions. Looking down onto the left also, the right eye is up, left eye is down. Looking up also, right eye is up.
Skew deviation.
Yeah, correct. So that means this disconjugation is retained in the same manner in all directions of case. Maybe more separation may be more there on looking into the upper this position may be more disconjugation, but overall it is retained in all positions of the case. When you find that position, you always think of a skew deviation. Is a disconjugation different direction? No, that's a skew deviation. Now let us see the rest of the video of the patient. When he's asked to walk about, he falls towards the left side. He's going to the left side, same direction as the head. He's going towards the left side.
Did we check the eyes separately, sir?
Separately, you will see that every movement will be normal. But only thing is, in that case, we cannot be able to find out any restriction. You'll be focusing on the eye with the finger. Only when you do the version, when you do the version,
then we can decide whether it's a muscle or the skew, no?
No, but again, but the problem, or last I told duction movement, if it's mild paralysis, you cannot detect that thing. It'll get correct. We do not know there is a normal range of movement for that particular patient or not. We only check the adduction movement. Subtle weakness, always you have to do the version movement, find out the disconjugation. Okay, so he has got a lateral pulsion to the left side, and both neck, head, and trunk. So where is the lesion?
So left midbrain.
No, right midbrain or left medulla. If it is a medullary lesion before crossing in the same side, after crossing in the MLF and the midbrain should be on the opposite side. So
no, here the left eye is up, no?
No,
here the left eye is up, no?
No, right eye is up, left eye is down. Right eye is up.
Oh, right eye is up, then right medulla.
Right
midbrain.
Right midbrain or up pons. We thought right inferior rectus, no? That means right eye is up, left eye is down. Okay, this is the possibility here. So what investigation you want? MRI. MRI shows involvement to the thalamus.
MRI brain.
The MRI shows. Can you see the MRI now? Middle thalamus and the upper midbrain on the right side.
Yes, sir.
Okay. So what he had was actually a skew deviation, which is very prominent. Because of the head tilt, we thought it may be due to the compensating head tilt due to the oblique paralysis. But actually, the head tilt was a part of the trunk, part of the gravis septi pathway affection, producing a lateral pulsion. So, this is the pathway. The anatomical structure is involved to produce a lateral pulsion is the gravis septi pathway. The direction of the subjective visual vertical tilt corresponds with the direction of the body lateral pulsion. consistent with the lesion ascending graviceptive pathway. Now, what is this pathway? With just one sentence, this pathway arises from the otolith organs, convergence with that on the superior vertical semicircular canal, at the level of the vestibular nuclei to subserve vestibular function in the pitch and the roll plane. These signals are passed on to the oculomotor nuclei and the cortical centers with perception of the verticality. So this is the pathway from the otolith on the left side. I don't know whether you can see on the left side, and the superior semicircular canal. It goes to vestibular nuclei, cross to the opposite side in the medulla, ascend in the MLF, and some of them end in the internucleus accumbens, and some of them go to the thalamus and then to the cortex. Okay, so anywhere in the lesion pathway, you can have a tilt. If it is before crossing, as in the case of medulla, it is to the left side. After crossing, it is again to the contralateral side. So it's ipsilaterally before the crossing, contralaterally after crossing. That is a tilt of the tongue and lateral pulsion seen in lesions of this graviceptive pathway. So you can have even isolated thalamic infarct in itself can produce a skew deviation. Need not necessarily be implicated in the midbrain. Some people postulate it is due to the extension of the involvement to the midbrain. Even otherwise, without that, also sometimes you can see skew deviation with thalamic lesion. So, any questions? Little tough case, eh?
Excellent, sir. Excellent.
Okay, thank you. Now I'll show you the literature. Skew deviation as initially manifested pyramidal thalamic infarct. See, in 8 out of the 14 patients, in unilateral pyramidal infarct, this is described by this thing. And in addition to the vertical ocular misalignment, these patients had a head tilt to the opposite side of lesion, ocular torsion, and subjective visual vertical tilt. Okay, shall I go to the next case? Or any questions in that case, please ask.
Sir, in case of vestibulopathy, just I'm asking just out of curiosity.
Please.
Suppose we have got a vestibulopathy on the left side, in like this patient. So can you have when the fibers are going to the midbrain and the medulla, and then they're crossing and going to the MLF and to the opposite side? If there is any problem, we can get the same type of result, no, sir?
Exactly, same. If you get a vestibulopathy on one side, that is an acute vestibulopathy. If you get acute vestibular neuronitis, you see happiness in the patient, the first 3 days, the patient will tilt to the same side of lesion. Especially when you close the eyes, the patient falls towards the left side. But through 2-3 days later, that get compensated because the opposite side will take over and will be corrected. The acute vestibulopathy, there is a lateral tongue lateral pulsion to the same side of lesion. But this is correct, exactly correct.
Thank you, sir.
Thank you. Okay. Any questions? If anyone wanted the pathophysiology skew deviation, how does it occur? I can tell later on if you want. I can tell just now, but most of you know that's why I'm not talking about this now. Okay, shall I go to the next case?
Yes, sir.
Okay. This is a story of a 15-year-old lady. This patient I saw just 1 week back, and this is referred to me by Dr. Amit. She first noticed a wrist drop in 2012. That is about 12 years back. According to her, there was no weakness of the finger extension. That is an educated lady. She said, only problem was his wrist coming down. I could move the fingers very well. She was given steroid at that time, but the weakness remained like that without any improvement. Subsequently, she went to many places. All of them have been given steroid, and she's continuing on that medication. 4 years later, patient noticed difficulty in extending her elbow. Again, 2 years later, patient noticed difficulty in elevating her arm. Noticed loss of finger movements in January 2023. That is about 11 years after the wrist drop. In October 2023, she noticed difficulty in elevating her right upper limb. Noticed numbness of the tips of the fingers of the left hand for the last 2 months. So the story started 11 years back. Patient noticed wrist drop. Then followed 4 years later by noticed difficulty in extending her elbow. Then again 2 years later, patient noticed difficulty in elevating her arm. Noticed loss of finger movements in January 2023. Then in October 23, she noticed difficulty in elevating her right upper limb. And so just the numbers, the tips of the fingers of the left hand for the last 2 months. No complaints pertaining to the lower limbs. So look at the video very carefully. This is a position which shows there's no wasting. The lance is very flabby, hypertonic. Shrugging of the shoulder was normal, but left was 0 power. She could not keep it at all. That is again weak, but about 3 plus power. Elbow flexion was also weak on the right side, but she could do it a little bit. But 0 on the left side. Eliminating gravity, she could not extend or flex the elbow. Again, exercise 0. Shoulder extension is also 0. Just 1 or 2. Just weak. Flexion is also weak. Inversion. Sorry, inversion was also weak. On the right side, it is good power. External rotatus, internal rotatus about gain 4.
Correct.
Right. Elbow is normal on the right side. On the left side, it is 0. It's already told. Wrist extension is 5 on the right side. Left is 0. Finger extension is 0. And the second part of the video, the finger flex is normal on the right side. Look at the left hand, what is happening. She was able to flex the middle 3 fingers. That is weak, but see, she's able to do that on the middle 3 fingers. But thumb and index finger 0. Individual sublimens as well as profundus. They're all normal on the right side. Pollicis longus normal. But profundus of the little finger was weak. That is still able to do about 2 to 3 power. But for the index, nothing, no movement at all. But the pollicis longus also 0. Pollicis brevis weak. Extension weak 0. Right hand, it is normal. Left side, she could not do anything. No movement. You could not do any movement at all to the finger abductors. That is okay with the right hand. Lower limb tone power normal. Neck of the reflexes or reflexes sluggish. Right upper limb just 1 plus. It's absent. Supinator. Bilaterally it is absent. Triceps absent bilaterally.
Properly, there is nothing to be
All were absent. Finger pressure
done.
absent. Knee jerks well elicitable. Ankle jerks also one elicitable. One plus. Plantar flexor. Sensory examination is normal.
3, 4, 5, 6, 7, 8, 9, 10, 11.
This pain is equal on both sides.
ഇതും തമ്മിലോ ഇതും തമ്മിലോ ഒരേപോലെ ഇതോ ഒരേപോലെ എന്ന് പറയണം അമ്മ. എനിക്ക് ഒരു വാക്ക് തെറ്റിയതുകൊണ്ട് ഇതും ഒരുപോലെ ഇതും ഈ കുത്തുന്നതും ഇതും ഒരേപോലെ.
Vibration is equally present bilaterally.
ഇപ്പോഴോ ഉണ്ടല്ലോ, ഇപ്പൊ ഉണ്ടല്ലോ, ഇപ്പോഴും ഉണ്ടല്ലോ, ഇപ്പൊ ഉണ്ടല്ലോ.
Joint sense is normal again, both sides.
ഈ വിരലിപ്പോഴാണ്. ഇപ്പോഴോ 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 ഇപ്പോഴേ 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 ഇപ്പോഴേ.
Okay, this is the finding. So, examination motto, no wasting of any muscles, hypertonia of the left upper limb, power left upper limb, shoulder shrugging normal, grade 0 power of abduction, adduction, flexion, extension, and internal external rotation of the left shoulder. All shoulder muscles are weak. Grade 0 power of the elbow flexion and extension. Wrist extension 0, finger flexion, wrist flexion grade 2. Finger extensor pollicis longus, extensor pollicis brevis grade 0. Finger flexion of the thumb and index finger again 0. Finger flexors of the middle 3 fingers grade 2 to 3. Small muscles grade 1. In fact, the only preserved muscle seems to be the middle 3 fingers of the left upper limb. Then right upper limb, shoulder shrugging normal. Grade 3 power of abduction, grade 4 power of adduction, internal external rotation, grade 3 power of elbow flexion, grade 4 power of flexor digitorum supplying the right little finger and probably ring finger also. Other muscles are all normal. These are the only 4 muscles which are weak on the right side. Both lower limbs normal power. DTR, both upper limbs, all reflexes absent. Lower limb, both knee jerks normal, ankle jerks normal. Plantar flexor, sense system normal. So, what is your likely diagnosis? Duration of 12 years duration.
Emma from
Pardon? Multifocal motor neuropathy with conduction block, correct?
Yeah.
Yes, sir.
Okay. Right. Why can be motor neuron disease? Progressive muscular atrophy type. Pardon?
No wasting
Wasting is not there.
Wasting is
Correct, exactly. Then even after so many years, there is no wasting. So it's a typical case of multifocal motor neuropathy conduction block. Now, what made you think? Suppose if the duration is short, also, what is the point which favors a multifocal motor neuropathy conduction block? The one important. No, the point is got the relative is 0 power of the flexor digitorum profundus of the index and the thumb, and 3 power of the other finger flexors. Classical, the so-called pointing index sign. That tell you that can occur only with involvement of the median nerve. That's anti-indocious nerve. That can have selective severe involvement. That is the basis of the median nerve friction producing pointing index sign. So that shows that that involvement is fitting with the nerve pattern, wherever it is.
And why is the third finger not affected?
Because it's a crossover, no? Because the middle part of the profundus is a single muscle. Part of it supplied by the ulnar, part of it supplied by the median. So in the median is affected, the maximum affection will be for the thumb and index. less affection only for the middle finger because that's also receiving some supply from the crossover supply from the ulnar nerve. The same muscle. That is why pointing index sign is the name given because only the index is pointing out in anti-intrusional environment. Okay, no wasting even after 10 years. Involvement in the distribution of the nerve, maximum action lateral 2 fingers, pointing index sign. No, in fact, last week, Joy was asking whether MMF can go for years. No, this is the example where the lady has been having it for 12 years. So investigations I will show you, it shows investigated outside.
Can
That
they have
is-
wasting after several years? Can they have
Pardon?
wasting also?
They can. Long duration, this can have wasting. Then it becomes a problem, whether it is some kind of axonal involvement but when there is no wasting, we are very happy because we know it's a diabetes. But they definitely can have wasting and the disease is a chronic one. That is why multifocal mononeuritis is one condition where you can have wasting. So look at the in the CS parameters. This is done in 2017. Let me see. 17. That is 4 point is a conduction block there at the S point, which was not there in the right median. Look at the left ulnar again, there is a conduction block 8.8, 1.4, not present on the right ulnar. Look at the radial again, on the left side it is there at the Eps point, but not there on the right side. Look at the musculocutaneous, again this amplitude is very low on the left side, normal on the right side. Suprascapular nerve is affected both sides, left as well as right. Clinically also right got affected. Axillary left is affected, right is not affected. And see the nerve sensory conduction is perfectly normal. F5 latency is also normal. Why the F5 latency is normal with this thing?
Maybe all fibers not involved.
Pardon? It's good.
All
Why?
fibers will not be involved.
Correct, exactly. Because even though there is a conduction block proximally, the block is not affecting 100%. Okay, some of the fibers are there which are able to transmit the impulses producing a latency. Even two fibers alone behind that will carry the impulses with a normal latency. That is sometimes you find F latencies. So it is surprising, no? Which is such a degree of loss with weakness and that much of weakness is got a normal F5 latency. So the investigation of the NCUS was repeated in 2019. Again, from outside, the came shows the same thing. There's a conduction block in the median, the left ulnar, left radial, same. And musculocutaneous nerve on the left side, axillary nerve on the left side, and left supraspinatus, and both and left supraspinatus. Right side was also decreased in amplitude, not as much as on the left side. Sensory condition was normal. Again, look at the F wave, again normal. 38, 23, 29, except one is affected. Left median has got a prolongation, otherwise all normal. This is what else you need now to confirm it.
Antibody testing.
So which antibody? GM1 antibody. Yeah, okay. Anti-glycogen GM1 antibody was done, which is negative, which is normal range.
That may be normal.
Yeah, so that may be normal, correct. That need not necessarily be abnormal all the time. So everything has got certain margins now. You have to keep that in mind. Clinical is always take the superior rather anyways. This is what exactly happened with this patient. They laid on the test, it was not put on specific treatment. That is why she went on having this weakness for so many years. Go for the clinical diagnosis, always superior to any of the investigations. The CSF was also done from outside, which is also normal. 35 protein, 2 cells. And they did CSF oleoconal band, it's again negative. So what do you do now?
PET scan করতে হয় PET
Pardon? I didn't hear you. Can you repeat, sir, once again?
PET scan
Immunoglobulin.
Immunoglobulin. Right. Now, the patient came with an MRI. This is the MRI of the cervical spine, which is normal. I'll show the other finding. This is axial cervical spine. Again, normal. Now look at this film. There's a stiff sequence.
Nerves are thicker.
Yeah, correct. This is another cut showing the components. This is the sagittal cut again showing the thickening of the plexus here. I'll show the static picture later on. So we did a contrast. This is a plain and contrast. There was no contrast enhancement. This is the T1 without contrast. Then that's a T1 post contrast. There is no enhancement of the nerves. So you can see the picture now. This is the thickened brachial plexus. Bilaterally, it is there, more prominent on the left side. Again, can find in the bilateral thickened plexus. So I did it after coming here. I did a repeat NCS. Again, you find the same finding. The left median they become absent now. The point initially was elicited. Now it will become absent. Again, left ulnar it will become absent. Radial amplitude has now come down. The axillary amplitude is less bilaterally, and muscular weakness are on the left side. And sensory control still remains normal. FAV latency is also normal, except the radial it is prolonged on the left side. Sorry, this is the one which is almost normal. FA latencies. So she's on IVIG now. This is yesterday. She's admitted in this hospital taking IVIG. So that's the story of the patient. The dictum is that don't rely on the investigations too much. You think clinical possibilities and treat. Now, sometimes, no, to clarify certain points, it's a purely motor neuropathy characterized by deficits in the distribution of single nerves without associated sensory loss. On the other hand, motor neuron disease characterized by motor deficit without sensory loss, but an important distinction from MM is that it occurs the distribution of spinal segments rather than the single nerves. That's important to appreciate. In MMN, the pattern of weakness takes the distribution of the nerves, whereas in motor disease, it does not take the distribution of the nerves. It will be patchy in the segmental patchy involvement. Ulnar median nerves are the most commonly affected. And another point again, taking my side. Taking this case, I was also asked last time by Joy whether it can affect only part of the nerve. Yes. There may be striking difference in the severity of the involvement of the different muscles supplied by a common nerve. This is presumably due to fascicular involvement. They may come to you with only finger drop of middle two fingers before any of the fingers getting affected. Subsequently, other fingers get involved. But the initial manifestation may be only for the middle two fingers and radial, and then maybe going also confusion with the patchy involvement. And this patient had pricking pain, pricking-like sensation on the paresthesia of the tip of the little hand. See, mild sensory disturbance may occur, and patient occasionally in a vague numbness and tingling of the affected limb, just like our patient. These sensory symptoms are not accompanied by alteration of the snap potentials on electrodiagnosis study. This is all from literature. I think this I will skip. Caesar protein can be normal, And IgM granulocyte antibodies is only in 40 to 50%, not all. More than 50% may be negative. So don't rely on IgM antibody all the time. The difference between MADSM is that, in MADSM CSF protein elevated and sensitive finding. And the chronicity is associated with axonal loss. And at that point, patient may develop muscle wasting mimicking motor neuron disease. There is also another entity called MMN without conduction block. See, absence of conduction block should not deter you from diagnosing a diagnosis of multifocal motor neuropathy. The multifocal motor conduction does not differ clinically from MMN without conduction block. In a comparative study of these two groups, the distribution of nerves involved, weakness, etc., are all same in both the groups. Subtle differences have been described, but these were not significant, and both groups responded equally well to IVIG. It is not clear if patients seropositive for anti-IgM antibody have a different clinical course than seronegative patients. So that is a point to remember. So when there is a doubt, if there is a demyelinating pattern, is there even with the conduction block, you have to treat for the benefit of the patient. Don't think of only motor neuron disease or MAMA.
Sir,
Yes.
is there any other possibility like MMNCD obviously should be considered in this patient and treat with IVIG? The second is that most of these conduction blocks are proximal. So,
Correct.
So whether it is a brachial plexus primarily which is involved and leading to manifestation, something which is hereditary or in that line.
Right.
Which is
that what you said is correct. This is one of the important DDs, hereditary liability to pressure palsy can present like that. But here, in fact, if you look at the clinical picture, not only the pattern of involvement is the nerve pattern. The classical example is anti-introsseous nerve involvement here. That is a point I was trying to highlight on the very beginning. See, on the left hand, the only muscle spared was that of the middle three fingers. So theoretically, that can also occur with the brachial plexus involved, brachial plexus selectively, but this is too striking. The so-called classical pointing index like phenomenon.
Okay.
But otherwise, it can definitely fit in with nowadays there is an entity called focal CADP. Focal CADP is only confined to one brachial plexus of one arm, remaining progressive for a long period of time. Or one or two nerves, trunk or nerves alone may be affected. Again, progress is called focal CADPs. I think I back I presented one patient presenting with ulnar nerve mimicking Hansen disease with the nerve thickening and all, which I don't know whether I remember or not, that are treated as a focal CADP.
So can we consider the upper limb variant of CADP because the MRI brachial plexus is showing diffuse hypertrophy rather than the focal hypertrophy?
That can occur with any of these conditions. That can occur with the CASP, can occur with multifocal motor neuropathy, can occur with the CADP, all can produce this hypertrophy. But the clinical point again, CADP is the sensory potentials are not, sensations are not affected even after so many years. If sensations are affected, it is MADSM, multifocal MADSM. Again, CADP variant. They are all variants of CADP only. But sensations are spared. Pardon?
Do we see these type of hypertrophy in the plexus in MMCB, sir?
Yes, definitely it can be seen. Definitely can be seen. If you had heard Dr. Kathirkar's talk, most of the toxic cases present cases like MMC with hypertrophy in the nerves. Classic example, this case alone, see, even after 12 years, his sensation is not affected.
What by the pathophysiology of the hypertrophy, sir? Because there is only conduction block is there. So why the roots are hypertrophy?
Because that roots hypertrophy, because the demyelinating nature, he not only acquired, even hereditary neuropathies of demyelinating etiology like CMD can have recurrent demyelination, can produce this onion bulb appearance and hypertrophy. That is a hypertrophic variety of CMD. So again, the pathology is demyelination. That will become hypertrophic. That's so-called onion bulb appearance of the nerves. but not seen axonal variety, only emanating type of CMT. Sometime back, I showed one case of this, neurophysin abnormality with hypertrophy of the nerves with severe pain. You remember, one month back. He had also got severe hypertrophy. The only point was hypertrophy of the nerves. And I had given him rituximab and the patient improved. He did not improve with any other treatment. Okay, any questions? Okay, shall we stop now? Am I audible?
Yes, sir.
Yes, sir. Yes.
Okay.
Thank you, sir.
Okay, good night. Good night. See you next
Night.
week.
Thank you, sir.
Good night. Okay, next week. Good night. Good night.
Right,
Thank
sir.
you. Good night. Thank you. Thank you. Thank you.
Thanks.
Good night. Good night.